Good day and welcome to an exciting episode of Debunking the Myths. My name is Luvuyo Mdeni. Now, as you would know, this is a program where we discuss the myths and anything that you might want to know regarding COVID-19. Now, as South Africa has moved from level 5 lockdown, in fact, level 5 lockdown, we moved to level 4 lockdown, and now this week we moved to level 3 lockdown. A lot of the concerns that you've sent regarding this week have been the decisions behind why the country has gone to level 3 lockdown. Now, in today's program, I'm very fortunate to be joined by Professor Shabir Madhi, who is the Professor of Vaccinology at Wits University. Professor Madhi will today join us in terms of debunking some of the questions that you have sent to us via the WhatsApp line. Professor, thank you very much for agreeing to this interview. I just wanted to find out, before we go on, can you please briefly tell us about your experience with COVID-19 and how it's been like the past few weeks for you?
Okay, so my background is I'm a pediatrician by training, and then I sort of specialize in infectious diseases with a specific focus in vaccines. And I've been studying respiratory viruses and respiratory pathogens for the past 24 years. I belong to the University of Witwatersrand, or rather I work at the University of Witwatersrand, where I've got a research unit. And our research over the past 24 years has really been focused around what we call the epidemiology of respiratory pathogens, both viruses as well as bacteria, and more specifically, how we can actually prevent it, especially by using vaccines. So we've done a lot of work in that regard. More recently, what we've done, obviously, over the past 3 months, is that we've become much more involved in COVID-19 because it is caused by SARS coronavirus 2, which is sort of a respiratory virus. Its main modality of spread is by respiratory droplets. So the work that we're currently doing on COVID-19 includes doing sort of epidemiological studies in terms of understanding what contribution COVID-19 has got to people being hospitalized for pneumonia or other illnesses, in addition to which we're also looking at how COVID-19 might be affecting pregnant women and healthcare workers. So that is part of the work that we're currently involved in. Personally, also what I'm obviously involved in is sort of providing some advice at different levels in terms of what I think should happen in a country together with other colleagues.
Of course, Professor, we call this show Debunking the Myths, and we invite our Facebook audience to send us questions where if they want to know anything specific about COVID-19. Now, one of the first questions that we had here, and this has been a concern for many, in terms of the country moving from level 4 to level 3.
Mina okhulumayo uNdumisa kwangema Newcastle. Cha, angiyiboni malento yokuthi siye ku level 3 ekubeni izinamba zecorona zikhuphuka ngalendlela ezikhuphuka ngayo. Okusho ukuthi phela masiqhubeka siya ku level 3 kanje uzophela abantu la. Kahle kahle ikhona vele yona into okuthiwa icorona nama ngisazi mase kunje.
So it does appear to be counterintuitive that we're going to a lower level of restrictions when there's increase in terms of number of cases. So that seems counterintuitive. But I think we just need to understand why South Africa went into a lockdown and what objectives were behind the lockdown. So South Africa, unlike many of the Northern Hemisphere countries that went into a lockdown at a very different stage of the outbreak. In the Northern Hemisphere countries, in many of the European countries, in the United States as an example, they went into a lockdown at the time when there was a surge in terms of the number of cases, when they were very much reaching the peak of the epidemic. And the reason why they went into a lockdown is that they needed to slow the rate of transmission of the virus so that there was less demand on the healthcare facilities, which were becoming completely overwhelmed. So that's why those countries went into lockdown. In contrast, the reason why South Africa went into lockdown is we're one of very few countries that went into a lockdown at the very early stage of the outbreak. And the reason for us going into a lockdown is not the same as to the reasons why the Northern Hemisphere countries went into lockdown. Most of the Northern Hemisphere countries The reason we went into a lockdown is really can be summarized for three reasons. The first reason is we were seeing an increase in terms of community transmission, and what we were wanting to do was to slow the rate of transmission of the virus. That was the first reason. Some people, unfortunately, mistook that the lockdown was going to get rid of the virus. The lockdown was never going to eliminate the virus. And even if we stay at level 5, we would need to stay at level 5 until a vaccine becomes available for this virus to be eliminated. So a lockdown on its own doesn't eliminate the virus. But the first thing was that it provided us an opportunity to try to slow the rate of community transmission of the virus. The second reason we went into a lockdown was to try to buy our healthcare facilities some time in terms of becoming better equipped to deal with what is going to be the inevitable increase in terms of number of COVID-19 cases that are going to require hospitalization. So that was the second reason. So during a 5-week period of the lockdown, and even now, the healthcare facilities are equipping themselves to deal with the surge of cases that is going to occur at multiple fronts. Be it to make sure that they got enough oxygen, enough beds in the facilities, be it to make sure that the staff have got adequate personal protective equipment so they don't become infected when we see an increase in terms of number of cases. Now, the third reason we went into a lockdown, and probably the most important reason from my perspective, is that it was provided us an opportunity to be able to identify individuals that were infectious, to put them into isolation, to trace their contacts, and put a contacts into quarantine.
I'd like to bring you to another question that we had, and this question basically speaks about hotspots.
Hi, this is Mkhululi Mbelashe, right? So I just wanted to ask, since we've managed to identify the hotspots in South Africa, why can't you just use the same method they use like in UK, which is used by NHS, where they're able to crack individuals who have managed to contract the virus and other people that have been in contact with that person?
Right. So the correct thing to do is we should try to identify hotspots in the country. To be able to identify hotspots, what it requires is that you need to be doing systematic testing, right? And the type of test that you actually need is you need to do what we call a PCR test, where we take a swab from the nose and then we look for the genetic material of the virus. And that tells us whether an individual is actually infected or not. And we need to do that in a very systematic manner throughout the country to be able to see which areas have got more cases than other areas. So that's the most sort of robust method that we can use. Now, the problem that we face in South Africa, so that is what should happen. But the problem that we face in South Africa is that we've got a crisis when it comes to our ability to do testing, especially to do testing and to get a quick turnaround of the result. Now, South Africa has got a population of close to 59 million people. Okay, so it's impossible to test 59 million people. And even when testing, we need to remember you can't just do a swab today and forget about that person for the next 3-4 months. Because what we know about the virus is that people are continuously being exposed. We also know that 70% of people that are infected with the virus won't have any sort of symptoms. So they'll be completely asymptomatic. Right? So they won't have a cough, they won't have a fever, they won't have a sore throat or anything, but they will still be infected with the virus. Right? So we can't go about testing everyone to identify who is actually infected. But like I said, the big challenge that we face is that even if we were just to target people that are symptomatic, that have got signs and symptoms of COVID-19, the amount of tests that would be required is something which our laboratory system simply can't cope with. Mm-hmm. Right now, the reality is that in the laboratory services, especially in the urban metros, it's taking anything between 5 and 14 days for a result to become available. So what does that mean? It means that we can still tell people, well, you might have been infected 2 weeks ago if you're only getting your results 2 weeks later. But by the time that person gets the result 5 days later, let alone 2 weeks later, that person, in fact, is probably no longer infectious. A person is most infectious, is most likely to transmit the virus the 3 days before they become symptomatic, up to about 5 to 7 days after the onset of symptoms. So if you're only giving a result to someone 7 days after the symptoms have started, it's like doing a pregnancy test but only giving the lady the result after she delivers the baby, which doesn't make any sense. Okay, so the problem is that, and we're not unique in this, right? There's many other high-income countries that have got the same sort of constraints in terms of being able to do the type of testing that's required to characterize hotspots in the community, right? At least using the testing method. So unfortunately, that is not an option. What's happening right now is our laboratory systems are so completely overwhelmed that those individuals that should be prioritized for testing, and by those individuals, I'm referring to people that are hospitalized. Like when someone is hospitalized, we need to know whether that person is testing positive or not, because that will determine the management of that particular individual.
Wow, that was another exciting episode of Debunking the Myths. I'd like to say thank you very much to Professor Shabir Madhi, who's a professor of Vaccinology at Wits. He's also the director of VIDA, which is the Vaccines and Infectious Diseases Analytics Unit. And I'd also like to say thank you very much to you who sent us your question via our new WhatsApp number. So if you have any questions that you would like answered regarding COVID-19, please send us a WhatsApp message to the number on your screen now. And for me, Luvuyo Mdeni, I'd like to say thank you very much for watching this episode and bon voyage.